Good afternoon to one and all present here. I am Dr. Raviteja Kolli, one of the doctors, medical officer from Chennai, Tamil Nadu. I'll be presenting about pancreatogenic diabetes. Pancreatogenic diabetes is also known as type 3C diabetes mellitus, which includes both structural and functional loss of glucose regulating hormone insulin secretion in context of exocrine pancreatic dysfunction. In type 3C diabetes mellitus, there is destruction of alpha cells and beta cells, which leads to deficiency of both insulin and glucagon. The American Diabetic Association classified diabetes as type 3C diabetes mellitus as updated in 2022. It is commonly overlooked and misdiagnosed as type 2 diabetes mellitus. Around 80% of type 3C diabetes mellitus is due to chronic pancreatitis. The other causes include hemochromatosis, cystic fibrosis, pancreatic trauma, pancreatic cancer, pancreectomy. So the primary objective is to present a rare case of diabetic ketoacidosis in patient of type 3 diabetes mellitus, secondary due to chronic pancreatitis, and emphasize the importance of accurate diagnosis and role of multidisciplinary approach in improving clinical outcomes. Let's move to the case presentation. A 46-year-old male came to emergency department with 10 episodes of loose stools for the past 2 days, and he also had abdominal pain and cough for the past week. He also had a history of loss of appetite, malaise, and unintentional weight loss for the past month. The patient is a known case of systemic hypertension and also a type 2 diabetes, for which he is taking metformin and amlodipine for 8 years. The patient also was consuming alcohol and smoking for 25 years. On examination, the patient appeared dehydrated with sunken eyes, lethargic and emaciated. His vitals showed pulse rate 96, blood pressure 150 on 90, SpO2 96%, respiratory rate 28%, random blood sugar levels showed 254 milligrams per deciliter. Physical examination revealed pallor, muddy conjunctiva, and dry mucosa. Routine blood investigation showed anemia and elevated level of ALP. The autoantibody panel was negative, and urine analysis showed glycosuria, and urine ketone was positive. So these are the blood results. Hemoglobin is low, and ALP is more than 1080. And non-contrast CT abdomen was done, which shows chronic calcific pancreatitis. The patient was diagnosed with DKA due to the symptoms and elevated blood sugar levels, positive urine ketones, and metabolic acidosis. He was started on DKA protocol and was started with isotonic saline along with insulin infusion to manage hyperglycemia. Potassium supplementation was administered to correct hypokalemia. Electrolyte levels were monitored closely throughout the treatment. The diagnosis of type 3C diabetes mellitus was based on criteria proposed by Ewald and Bretzel in 2013, which includes presence of exocrine pancreatic insufficiency, pathological pancreatic imaging, absence of type 1 diabetes associated autoimmune markers. So all three major criteria must be present to make a diagnosis of type 3C diabetes mellitus. The minor criteria includes impaired beta cell function, no excessive insulin resistance, impaired incretin secretion, low serum levels of lipid-soluble vitamins A, D, E, and K. As the patient is stabilized, oral intake was resumed with high protein and fat restricted diet. Pancreatic enzyme replacement therapy was introduced to manage exocrine insufficiency and digestion. Long-term glycemic control was established using a basal bolus insulin regimen with regular insulin 8 international units and 10 international units basal insulin. The patient was counseled on the importance of strict alcohol and smoking cessation. Type 3C diabetes mellitus accounts around 1 to 9% of all diabetic cases, and most common cause is chronic pancreatitis. Chronic calcific pancreatitis is the primary etiology in this case, which involves inflammation-induced glandular fibrosis and atrophy of pancreas. Chronic alcohol abuse and smoking remains the most common etiological factors. Chronic inflammation leads to both progressive loss of both beta and alpha cells. which leads to insulin and glucagon deficiency. It is often misdiagnosed as type 2 diabetes mellitus due to overlapping clinical features, leading to delay in appropriate management. Type 3C diabetes mellitus involves both insulin and glucagon deficiency, making it a unique challenge for glycemic control. The management of type 3C diabetes mellitus is challenging, requiring a tailored multifaceted approach. Insulin therapy is often necessary as the disease progresses. All insulin based regimens must be approached with caution due to the risk of hypoglycemia. The deficiency of glucagon secretion from islet alpha cells make patient more susceptible to unpredictable episodes of hypoglycemia with carefully adjusted insulin levels. PERT is a cornerstone of treatment, improving digestion, promoting glucose tolerance, and enhancing the absorption of fat soluble vitamins. Nutritional counseling and the use of PERT are essential for addressing exocrine pancreatic insufficiency. This case emphasized the need for increased awareness and recognition of type 3C diabetes mellitus, particularly in patients with chronic pancreatitis or other pancreatic disease, and also chronic alcoholic patients. Misdiagnosis as type 2 diabetes mellitus can delay appropriate treatment and lead to severe complications such as DKA. A multidisciplinary approach involving endocrinologists, gastroenterologists, and dietitian is critical for optimizing the care of these patients. This case serves as a reminder of the importance of considering type 3C diabetes in patients with diabetes and significant pancreatic pathology. So these are the references. Thank you for your patient hearing.